question is, how long do we need to monitor before we can be sure that the patient doesn't have atrial fibrillation? And the answer to that is the longer we look, the more we find.
I think the longer you monitor in general, the higher the chances of finding AFib. The incidence of finding AFib at 3 years, it was around 30%. So the longer you monitor, the more likely you're going to find AFib. So 30 days of monitoring is clearly not enough.
I absolutely do not think that 30 days of cardiac monitoring is sufficient to rule out atrial fibrillation. If you look at the Crystal AF studies and as well as the real world studies, it took much longer than 30 days, 84 days in Crystal AF. I've also seen that in my practice. 30 days is not sufficient to rule out atrial fibrillation in these patients.
The majority of patients with AFib, especially paroxysmal occult AFib, will have no symptoms whatsoever. So these patients are ideal candidates for long-term monitoring 3 or 4 years with the ICMs.
Many of the important clinical guidelines now recommend long-term monitoring for patients with ischemic stroke, particularly in those in whom finding atrial fibrillation will change management or in whom you have reason to suspect a higher incidence of atrial fibrillation. And we know that the most effective way of finding atrial fibrillation is with an implantable device.
Sometimes get pushback from other doctors who say you don't need an implantable cardiac monitor, you should first do a short-term monitoring. I'd like to address that by saying that short-term cardiac monitoring only leads to about a 5% likelihood of detection of atrial fibrillation or flutter in the first 30 days. It's not enough, and most of our events occur in the first 90 days. And so you don't want to miss those patients. And we really need to gently but firmly push back and say, no, implantable cardiac monitoring is the standard of care for these patients, and it should be implanted in the hospital, and the data is very strong.